Today we are going to talk about cytauxzoonosis in cats, also called bobcat fever, a rapidly progressive and frequently fatal disease caused by the protozoal parasite Cytauxzoon felis. Bobcats are an important natural reservoir, while domestic cats are usually infected when an infected tick feeds and inoculates the parasite into the skin. The lone star tick, Amblyomma americanum, is considered the primary vector in the United States, although the American dog tick may also transmit the organism. Cases are most common during warmer months in regions where these ticks are active. After entering the cat, sporozoites invade macrophages and other mononuclear phagocytes, where they undergo rapid asexual replication and develop into large structures called schizones. These infected cells enlarge and obstruct small blood vessels, especially within the lungs, liver, spleen, and other organs. The resulting tissue hypoxia, severe inflammation, disseminated intravascular coagulation, and circulatory shock are primarily responsible for the life-threatening disease. When the schizones rupture, they release merozoites that invade red blood cells and form pyroplasms, producing additional hemolysis and anemia. Clinical signs often begin approximately 10 days after the infective tick bite and can worsen extremely quickly. Cats commonly develop profound lethargy, anorexia, dehydration, lymph node enlargement, tachypnea, dyspnea, jaundice, and a fever that may reach 106 degrees Fahrenheit. As shock progresses, the temperature may fall below normal, and the cat may become recumbent, neurologically abnormal, comatose, or die. Laboratory abnormalities commonly include non-regenerative anemia, thrombocytopenia, leukopenia, hyperbilirubinemia, elevated liver enzymes, and bilirubin in the urine. Diagnosis may be made by identifying small pyroplasms inside red blood cells on a stained blood smear, although these organisms may not appear until late in the disease. Schizones can sometimes be identified within macrophages obtained from a lymph node, spleen, liver, or bone marrow aspirate. A whole blood PCR test is more sensitive and should ideally be collected before antiparasitic treatment begins. Treatment must begin immediately. The recommended protocol is atovaquone at 15 mg per kilogram orally every 8 hours combined with azithromycin at 10 mg per kilogram orally every 24 hours for 10 days. Atovaquone is an antiprotozoal ubiquinone analog that binds parasite cytochrome B and disrupts mitochondrial energy production. Azithromycin is a macrolide antimicrobial that interferes with protein synthesis within the parasite. Even with prompt combination therapy and intensive supportive care, reported survival is only approximately 60 to 64%. Supportive care is essential and may include carefully administered intravenous crystalloids, oxygen supplementation, nutritional support through a feeding tube, and a compatible blood transfusion when anemia compromises oxygen delivery. Heparin may be administered at approximately 100 to 200 units per kilogram subcutaneously every 8 hours to reduce complications associated with abnormal coagulation. Handling should be minimized because stress and increased oxygen demand can worsen respiratory distress. Cats may initially deteriorate despite treatment, and survivors can require several days before their fever and clinical condition begin improving. Prevention depends on reducing tick exposure because no vaccine is currently available. Keeping cats indoors provides the strongest protection, while outdoor cats require consistent, cat-safe tick control, frequent tick checks, and prompt removal of attached ticks. Products containing imidacloprid with flumethrin or selamectin with seralaner have shown protection against transmission in studies. Cats that survive may remain lifelong carriers, so recovered cats should not be used as blood donors. The major takeaway is that cytauxzoonosis is not simply an infection of red blood cells. Its most dangerous stage occurs when parasite-filled macrophages obstruct the circulation and trigger hypoxia, coagulation abnormalities, and shock. Rapid recognition, immediate atovaquone and azithromycin treatment, aggressive supportive care, and year-round tick prevention provide the best chance of survival.